Well, Kelton, really excited to have you on joining us. Kelton Burbank is a very accomplished orthopedic shoulder surgeon and value-based care expert. I've gotten to know Kelton over the years in his work with value-based care, especially innovating on care delivery with integrated practice units. So we thought it'd be a great experience to kind of hear from Kelton himself, one of the few people that have done integrated practice units in real life, hear his story and kind of hear how he was able to navigate a complex healthcare system and healthcare practice to actually implement multidisciplinary orthopedic care. So, Kelton, really excited to have you on, and thanks for taking the time to spend with us.
Thanks for having me, Eric.
So, the first question I'd love to ask, just tell me a little about yourself, your practice setting, and how you got interested in the first place in value-based care and orthopedics.
So I think that I've always been a little bit of a black sheep in orthopedics, and probably that's because I was poisoned by doing a family practice residency before I did orthopedics, and that's a long, complicated story that we don't need to go into. But it's interesting. I went from being a generalist to now just being somebody that does shoulder surgery. But I think I've always been interested in the sort of the uh, different alignments uh, of incentives for surgeons and patients. They're not always equal. And I think the thing I remember the most is in talking about knee arthroscopy in people over 50. It used to be this very long conversation I would have with people about why they may or may not want a knee arthroscopy, because they would all come to me thinking that they needed a knee arthroscopy. And I remember thinking that it would take me about 45 minutes to talk to them about what science tells us about whether this is something that they really might want, what the other alternatives are. And in doing that, I would get about 0.75 RVUs, whereas colleagues of mine might take 10 minutes to explain to them that they would benefit from surgery and then do a 15-minute procedure and get about 18 RVUs. So I just always was curious about that, sort of wondering about how do you adequately explain to people what their choices are, and how do you avoid sort of high cost, low value care?
And it's kind of funny you bring that up because I'd say I have had a very few like one-star reviews, and I will tell you it's from folks who are a little bit overweight, who have mild arthritis, who come to me for a knee scope, and I convince them that a knee scope will make them worse, and they get mad because all we did was quote talk about the weight when that was the issue to begin with. And so those are my one-star ratings when people come in and expect surgery and they don't get the that answer that maybe they were looking for.
Couldn't agree more. And often they can go to somebody else, and we're not telling them that they're not going to get better with surgery. We're just telling them why surgery may not be something that they want to choose. And it's also interesting that you bring up the sort of the other factors that can be part of how a patient experiences pain, whether it's their anxiety, their depression, their weight, some other issues that they have. Patients don't always seem to factor in these other things, and surgeons don't either. You know, we're pretty automatic and mechanical on things, and as you know, the things that can influence how a patient experiences pain are really multifactorial.
And we'll get into this when we talk about the topic of our conversations on IPUs, but a lot of the failure, of course, there's an awareness from the patient side, and there's an inability for us to deliver that education. I learned about the inflammation in diet when I had patients come in saying, "Hey, I started eating broccoli and my knee's better." The turmeric, all that stuff, and then you're like, "Oh, you're hearing the same themes over," but like we don't learn it. We didn't learn it in medical school. We didn't learn it in residency. We don't learn it in practice. And patients come in online. And then now the other problem is that when we have this open access to radiology imaging, everything's a tear, partial tear, this. And they're calling and saying, with a very, very low grade partial tear, say, Doc, I guess I need surgery. And like, no, you don't need any of that stuff. But they have all these results in real time that I don't think always are a good service at the end of the day.
I agree. The language we use or the language that the radiologists use are really catastrophizing, aren't they? Like everybody has tears and ruptures and things like that, and they may or may not have any relevancy to what the patient is
Yeah.
experiencing.
They're
I can't tell
65
you
years old with a bad knee.
how many 80-year-olds I see with quote slap tears in their shoulder that
Yeah.
like they're really worried about this, but
Yeah.
it has nothing to do with what they're experiencing.
So, how understand that doing a family medicine residency, which is unique in itself for an orthopedic surgeon, is going to give you a different lens on how you view medicine in general. How did you start learning about value-based care? Because there's not a lot of docs and orthopedics who actually not only know about it, but actually implement. There's very few that actually implement value-based programs that are not related to some sort of bundle payment. So how do you start hearing about these
So
innovations?
probably like you, Michael Porter's name used to come up all the time, and then people started using a language that I was incapable of coming up with, but resonated with what I was thinking. So that Michael Porter picture of the value-based care book would come up, and then the value equation, right? Cost over outcomes kind of thing. Just heard it. And then I also was fortunate enough to work with Dave Ring. Sorry.
Yes,
Dave
yeah.
Ring and I were on a board together. Ring and I used to talk about these things about patients that came in, and they were fascinating how they were experiencing or how they would interpret things. So I used to tell him there's what I say, what I think I say, and what patients hear, and they're never the same thing, right?
No. Especially
So
when you're hearing it all at the same time in a busy clinic setting, and they can't get past that there was a X-ray that showed arthritis, let alone what the treatment is, the risk, the complication, all that stuff. They can't. It's hard for
so
a lot of
then
people to do that.
So yeah, so two things on that right away is there are two problems with the visit, right? There is the physician being pressed for time, like in their algorithm, they're looking for certain things, and then when things get out of their algorithm, like this patient is depressed, this patient is obese, this patient has other things going on that may be influencing their experience, it's hard for you to kind of get back into your track. And the other thing is it's really hard for patients to hear and digest what you're saying. There
Yeah.
is a period of time where they may even pretend that they're listening to you or hearing you, but they're not. And this became clear to me when in my town, like everybody with any medical problem comes to see me because I'm, it's a small town and everybody knows me. So I remember spending hours explaining to people exactly what was wrong with them. And then the next day they would call me. And in the first 30 seconds of talking to them, it was clear to me that they didn't understand a word of what I
Yeah.
said to them. And that's
Yeah.
an hour in a relaxed setting, not 15 minutes in a tight, orthopedic clinic schedule, right? So I began thinking about, what it is that we get across to patients and why that is and how these different factors can influence what patients decide. So I guess I originally came at this from the decision-making process for patients and the idea of shared decision-making being something more than just a platitude became of great interest to me. So I guess that's where kind of I hit on this.
And of course, Dave Ring being at Austin at UT where they're doing these integrated practice units. Um, and so I imagine that sort of osmosis started coming in. And so what happened where you were learning from them? Then what was the link between learning about value-based care in general, then learning about IPUs, and then saying, "Hey, I'm actually going to start an IPU or run an IPU at my clinical setting." What was that progression, and how long did that take?
So actually, myself and one of my colleagues, Lou Janis, we actually went down to the University of Texas in Austin for one of these 2-day value-based care things, and we're really interested in it. We saw how they did it. We participated in the talks, got to witness firsthand how they did it, and we absolutely drank the Kool-Aid. We thought this was the greatest thing in the world. Like suddenly it all made sense. And again, it was they were using a language that I didn't have the ability to articulate, but it absolutely resonated with what I had experienced. So I wanted to sort of imitate this. So we went back and we decided that we wanted to create an IPU within our organization. So we're a big multi-specialty group. We have 10 orthopedic surgeons. We have about 12 APs. We see a lot of patients every day. And what we thought we would do is we would create an IPU and we would have different people running the IPU at different days. So we would have just the way they set it up at Austin. So we'd have an AP, a surgeon, a nutritionist, a physical therapist, and a behavioral medicine person. And originally we started with just 2 per month. One was shoulder because I was interested in it. One was spine. because my colleague Lou was interested in it. But then we added hip and knee, and we had just some of our colleagues run them. And what we learned quickly was that there aren't very many people that are interested in actually doing this.
Yeah.
The idea of having our knee and hip colleagues doing this, it just didn't work because they thought it was a good idea, but it interfered with their ability to see patients quickly and efficiently, and interfered with generating surgical visits. And so it actually fell on its face almost right away.
Yeah. And we have a video on how to scale value-based specialty care. And when you go to a surgeon's practice as a patient, at least my thought is there's two options that you can get. Either the surgeon's going to say, we're going to do surgery, or I can't help you. There's no third option of let me walk you through a complex, comprehensive, non-operative, multidisciplinary program. Where I'm going to make sure you get your nutrition education, your physical therapy, your education about your condition. That's not an option. It's either I can do a surgery or you need to go somewhere else. And so that's why, if the incentives aren't lined for doing that multidisciplinary care, it's going to be very hard to get uptake, as you brought up.
No, I agree. And it felt like there was a big gap, as you point out, in between doing a surgery and sending them away. And in some ways, physical therapy would fill that void, but physical therapy felt a lot like the Monty Python skit where the Knights of Ni are up on the castle and they're trying to storm it, and they tell them to bring me a shrubbery. They're just anything to kind of buy some time. And it feels like physical therapy is like that. Like, why don't you go away for 6-8 weeks, and when you come back, we can either say that you've done physical therapy and you failed, so now a surgery is appropriate, or maybe you don't come back, which is maybe what I'm really hoping for. But we're not really diving
Yeah.
into treating you. There's a
Yeah.
whole other litany of things that we could think about to help educate you and help you make decisions that are best for yourself. So that's that.
Yeah.
You're exactly right there. The interesting thing was with some of our colleagues, like they would see these patients, but none of them would be referred on to the behavioral medicine person or the nutritionist. They all knew how to refer to PT, so the PTs were busy early on, but we weren't using the other
Yeah.
clinicians. And we began to wonder, like, does this make sense? We have this highly resourced clinic, but we're not really using everybody in it. Is this efficient?
Yeah.
So that's when we came up with the idea that maybe it would be better to have an alternative care pathway. Maybe it'd be better if we selected a group of patients for the IPU that had the highest probability of benefiting from that highly resourced clinic. So that's where we kind of created a sort of a sidebar, so that the idea was that the patients that came to the regular legacy clinic would just see the surgeons and the APs as per usual, but carefully selected patients we would take out of that pathway and put on a different pathway, which would be the IPU.
If you like this kind of content where we dive into real value-based specialty care topics with actionable insights that you can take home to your health plan or healthcare organization, click the link below, sign on to our mailing list, and we'll keep you posted of all of our different web-based and in-person events. This touches upon a few different things, both on which patients would benefit from an IPU. And I know most of the people listening know, or at least understand what an IPU is, being an integrated practice unit, a multidisciplinary model where we can give folks and patients the care they need about their condition, whether it's medical or clinical, or injections, PT, nutrition, mental health, social work. So you touch upon two things. One is finding the right patient from a clinical perspective, but then the other thing that we haven't talked about yet is that at your clinical setting, there's two types of patients. There's one where the organization is at no financial risk for, that gets treated like fee for service. And there's one type where they're at full financial risk for, where they're the insurer in effect, and every unnecessary dollar goes against the bottom line. Now, that is actually fairly common everywhere, right? Every major system, because whether you have delegated lives or an ACO, or if the system owns the health plan or vice versa. So it's not an uncommon situation. So how did you first of all figure out, okay, this is a patient that's risk bearing and we have risk for versus a fee for service patient, because it doesn't make sense to do a IPU for a fee for service patient. It's very hard. Also, they have multiple copays. It's not easy, and it doesn't really make sense from a financial perspective because you're not taking the risk for that patient. So how do you decide that first branch point of this is a value-based patient, this is a fee-for-service patient?
So our referral management team has that information available to them. So we decided early on, for a variety of reasons, that we were only going to do the IPU for our risk patients. And as you alluded to, there's several reasons for that. First is it's almost impossible to get same-day referrals for fee-for-service, so that's a practical reason not to do it. The second is that there's just a pile of copays that need to be sorted out, and that made it another sort of logistical reason why it didn't make sense. And the third is that there were sort of headwinds with the financial people that, creating an impediment to care for the fee for service might not be exactly what they wanted, particularly early on when we didn't know whether this was going to be something that worked or not.
And then walk me through the referral process. Who referred into the IPU? You said some of your colleagues would. Would you get referrals from other specialties, primary care or PT even?
So the way it works in our organization is that our primary care doctors send a consult for musculoskeletal care. So it'll be an MSK consult, and that'll go to the referral management people. So initially, what was happening is the referral management people would give me a list of all the orthopedic consults, and I would screen the charts, and I could just tell based on their past medical history in the chart who is probably going to be a pretty straightforward surgical consult and who probably had a number of other issues that could perhaps be influencing their experience of pain. So we would redirect those patients, the ones that I would select that were all risk patients, to the IPU. And that worked really well, but it wasn't sustainable because I would have to look at this list every day. And then what I ended up doing was creating a program in Epic, which would mine the chart and assign points for certain diagnoses. So for PTSD, anxiety, depression, it would look at certain meds that they were on. It would look at how many ER visits or urgent care visits they'd had in the last 6 months. It'd look at their hemoglobin A1C, their BMI, just these other factors, and assign them a score. So patients with a score over 10, we would call red patients, which a red risk patient would then automatically, through our referral management team, would come to the IPU. Yellow was sort of either way. So if the IPU wasn't particularly full, they might come to fill the IPU, or they might go to Legacy Clinic, and the green would absolutely go to Legacy Clinic. So that worked really well, actually. We were getting a lot of patients that we felt we could help in the IPU, whereas they might not get things addressed if they went to the Legacy Clinic. And you might say, well, what about their knee pain, or do you address that, or do you just start addressing their behavioral medicine issues? So patients that come in, we have an orthopedic person to evaluate them and address them. And some of these patients may be candidates for surgery, but they're not good candidates for surgery at this point because they need some of these issues optimized before they end up being referred to the surgeon. So it's sort of like if they came in and they were having chest pain or shortness of breath, you wouldn't send them immediately to the surgeon. You might optimize those medical problems. Similarly, we'd address these, but we'd also address it in the context of their knee pain or their shoulder pain, which in our experience, patients were much more likely to engage in this care, this looking at the behavioral medicine, looking at the nutrition, when we didn't, it wasn't like they came into the office and we said, hey, you need to go to the dietitian, or hey, you need to go see behavioral med. And 6 weeks later, they're in a behavioral medicine office, or worse, they're like, yeah, Burbank thinks it's all in my head. I'm not doing that. I'm going to go see another guy. That was all addressed at that day, at that visit. And again, I think the overall experience for the patient was much more positive in that we weren't ignoring their knee pain, but we also weren't ignoring their depression or their obesity or the other issues. We were addressing them all as a team.
And what were the so the reason I like that system a lot is because you have two it's kind of very elegant. If you're a fee-for-service patient, you're automatically green, right? If you're a
Well,
risk-bearing patient,
you can be red, yellow, or green still. You just
uh,
fee for service at this point isn't something that we can manage in our IPU for
right.
both logistical and other reasons.
So
So
the red, yellow, green was a clinical, but you're able to get at least stratify and you know, I mean, I imagine that that was a pretty accurate stratification system looking at the past medical history, especially with all these
so
diagnoses that get carried over.
so we collect PROMs on all of our patients. You know, we collect the PROMIS measures of anxiety, depression, pain interference, and physical function. And we've been trying to correlate our risk score with the PROMIS score, the PROMIS measures. And it turns out that your past medical history is actually more predictive of where you are with all of this than your PROMIS measures are. They kind of fluctuate up and down, you know, at any given time. But in large populations over long periods of time, we do see a very significant difference between the patients that we bring into the IPU compared to the patients that go into legacy in terms of average anxiety, depression, and even pain interference scores.
I believe that. And you know, if you have a diagnosis in your chart of anxiety or depression, that means you had to have been diagnosed or evaluated or treated for it, right? And so you're already at that, the chance of you scoring high on those PHQ-2s or GAD-2s or even the PROMIS measures for impairment of mental health, they're going to be high because you've already declared yourself. And we know the link between especially anxiety and pain is so high that it should be a very effective tool to recruit patients. And even if you don't have their problems for physical health, you've got their mental health ones, which is probably important.
So the beauty of the risk tool is it's your past medical history and it's calculated instantly in the chart and you're assigned red, green, yellow, and anybody looking at their schedule can see the patient's risk score. So you see their name, why they're there, and you can see red, green, or yellow. So that helps, and it makes our clinicians in the legacy clinic just sort of more aware of these things and more aware when they're going in to see that patient. And maybe this is a patient that maybe they need to refer to the IPU if appropriate.
Yeah.
So that's kind of in their head ahead of time. Um, but interestingly, the PROMs, as you know, it's really hard to collect them before the patients come in, and it's certainly hard to collect them before the patients are scheduled, right? So the beauty of the risk tool is this is automated. This is immediately upon an MSK consult, the referral management people can see whether they're red, green, yellow. They don't know their PROMs yet, right? So so that makes this process more automated and just makes it flow a little
And
easier.
invisible.
Our system, it worked out really well. And we're continuing to try to iterate on this. We're trying to tweak it. You know, do we have it exactly right? No. You know, we're looking at sort of what our capture rate is of the people that we think belong in the IPU. And certainly there are other portals of entry, as you know, in any system. Like some people just call the
Yeah.
department and the PSS staff do their best, but they aren't going to necessarily screen them into the IPU. So they might get away that, get to a different care pathway that way when it might be better for them to be in the IPU. But those are the things that we're working on trying to improve.
So from an individual patient perspective, let's say I saw a joint stock and he or she said, you know what, you got some depression going on, some anxiety, you're overweight, you might be a good candidate for the IPU. Walk me through what happens when they show up for their first visit. Like who are they seeing? Who are they interacting with? The Dell model is kind of everyone's there at the same time, I believe. I've been there too and visited. Is your model like that? Because when we did it at Henry Ford, it was more kind of in series, but there was one visit with everybody, and then we kind of would refer out. So how was the experience now with you all?
So I'll say two things. First, as they come in, um, when they're referred to the IPU, they're sent their PROMs and they're sent a video introducing the IPU to them. And half to two-thirds of the patients actually look at this video. The other third come in and they have no idea that they're in the IPU. And so it gets explained to them when they get there. So they come in, the first thing they see is an orthopedic AP who evaluates their musculoskeletal issues and also tells them about the uniqueness of the clinic that they're in and avails them of the opportunity to see the behavioral medicine specialist if appropriate, the nutritionist if appropriate, and the physical therapist if appropriate. And all of these co-clinicians are there co-located at that time. So we had some concern originally about whether patients would want to spend like an hour at this visit, but it turns out we run pretty close on time in our IPU, whereas in our legacy clinic, you could be pretty far behind. So patients
Yeah.
sadly are used to waiting a little bit and budget that into their time. And the other thing, in a worst case scenario, they come in, they see the AP as expected, and they decide they don't want any of this. So they've had an orthopedic visit that they would have had without the IPU. The IPU is just a sort of an add-on bonus if they want it. So we need to, in the next iteration of this, improve, as I said, the capture, making sure we're getting the appropriate patients in this sort of alternative care pathway. Again, I'm not sure I explained this well, but our legacy clinic runs just the way any other legacy clinic is. Patients come in, they see the providers, and they go to whatever is decided for them. What we wanted to do was create a process whereby we could run an IPU like they do at Dell, but at Dell, all patients run through the IPU. That just wasn't
Yep.
possible in our system. It would require every one of our providers to buy into this, want to do this, have the same interest and passion for it. It just simply wasn't the case. Orthopedic surgeons don't all want to do this kind of thing. So we wanted to create something that would get a defined population of patients. And that's, for us, it's psychologically distressed risk patients, and redirect them to this alternative care pathway with little or no disruption of our legacy clinic and the productivity of our legacy providers. And so we're actually quite successful at doing this. The legacy providers are happy because the red patients don't end up in their
Yep.
clinic. That's a
Yep.
win for everybody, the patient and the provider. And they haven't seen any diminution in their numbers or their surgical numbers or anything else like that. And the patients that do come to us first, that then go and are appropriate for surgery, are now sort of optimized for that surgery and likely do better. And as we collect more and more outcomes, as you don't want people with really uh, anxiety, depression, other things that can negatively impact their outcomes. Selfishly, you don't want that reflected in your outcome scores, right? So for us to be treating that and addressing that before, during, and after their surgery helps everybody.
So if you get somebody who's got pretty, say florid depression or anxiety that needs treatment, but is not hooked up into mental health treatment, you know, I would imagine that a comprehensive treatment for that depression anxiety is probably a little bit out of scope of the IPU, right? Certainly the mental health as it relates to the physical health is in scope, but what are you like, what can you do for them when you know that depression or the anxiety needs its own treatment, not just a consideration?
So they meet with a behavioral medicine specialist that day, and the behavioral medicine specialist doesn't dive into treating that at that point because that would be off-putting, I think. Rather, the behavioral medicine specialist comes in and tells them what the options are. Takes a history, kind of gets an idea of what might be needed, talks to the patient about that, and then together the patient and the behavioral medicine specialist or team member um, creates a care pathway for that particular problem for the patient. Similarly, they have a nutrition care pathway that they follow. They may have a physical therapy care pathway or even a care pathway with the AP. Occasionally, they ask to see the surgeon, who either um, helps disabuse them of the notion that they definitely need surgery for this and that's the only way to manage their pain, or acknowledges that surgery might be an option for them, but that there are some other things that probably would benefit the patient if we had in place prior to engaging in any kind of surgical treatment. I don't know if that answered your question or
It
not.
does, it does. So they'll see the behavioral health specialist, they'll kind of give them the rundown, and then if they need more dedicated treatment, do they meet with that behavioral health specialist one-on-one, or they get kind of referred to the behavioral health team via that first specialist?
It's both. So the
Okay.
behavioral medicine specialist is, active in the community doing this, and so they may have a good relationship with that person. They may be at a site where it's easy for the patient to get to that. We have in-person and virtual options for them, but at the time of the IPU, the treatment pathway is set up. So the patient will then, if they need to see a clinician, they'll set up that visit in the future. If they're interested in sort of our VR or our empowered pain relief programs, which can be done either in person or virtually, they'll set that up. And then follow-ups are usually done on the behavioral medicine side, although some of our patients like to come back and have follow-up on all these issues at once. Like they like to see the the AP or the surgeon again. They like to see the physical therapist again, and they like to see the behavioral medicine person again. And we actually like that too. But a lot of the work is done outside of the IPU, and then they come back for a visit to make sure all the pathways are managed, which is interesting. So our phase one was to integrate this and show that we could do it without disrupting our legacy clinics, and also to show that we had impact with outcomes, both reducing high cost, low value care, reducing TMA, and also improving outcomes. And we have shown that. We've shown about a $350 savings per member per 6 months when they come to the IPU, as opposed to controls, match controls. And we also have improvement in their physical function, their pain interference, their anxiety and depression scores, somewhere in the 3 to 5 range for the PROMIS measures, which, as you know, is at or near MCID.
Yeah.
So we are showing that, but what we want to do is take it to the next step. And so we recognize that phase one was good. We show that this can work. Everything's directionally favorable. What's the next step to really have impact? And there are a couple of things. Capture, as I mentioned, making sure we get the appropriate patients in there. But engagement is really the next step. We really don't know. We're not measuring what happens to these patients. They come in, they could engage with everybody, do really well, stay on all their care pathways, and that may be one type of patient. One patient may come in and say, you know what, I really don't want any of this, and just never come back again. And those two are being measured in the same pool of patients. So what we would like is a way to follow these patients along, whether that's virtually with some of the products that are out there that can do virtual care navigation, check in on all these pathways, remind patients to check in on their homework assignments, and then bring them back when appropriate, or even get a nurse navigator or something like that to check in on it. But that's the next step, and something that we're really excited about diving into.
Yeah, I was going to ask, like, after they leave those walls of the office, what happens to them? And as you point out, it's actually very hard to keep track of where they're going, because if they go in your system and they keep doing some physical therapy, or they see more with the BH folks, you can track it. But if they are not, then you have no idea on that. And I think that obviously we're biased. We believe the digital engagement is super important as well on that. One question I would have like to ask is, okay, how do others replicate this in their system? But you kind of laid it out. I mean, you laid out the steps that as long as the system has a risk-bearing pot of patients, whether you stratify by epic or other determinants, or you take, as they come in, like, it's worth doing a program like this. This morning we posted on LinkedIn about community health workers at Henry Ford, an article about how they're getting A1Cs down from double digits into fives by weekly check-ins, right? It complements the physician work. And guess what happens when you have an A1C that's 5.7 instead of 10.5, right? Less hospitalizations, better health overall, less cost of care. It's fairly straightforward. The ROI is there. And so I think you laid out a good pathway on how to replicate this. And one question, I know that you described the next evolution of the IPU, which I know you could be working on this next phase. But as you look on this journey, a question we always like to ask is, what are you most proud about from your career, and what are you most excited about? And I will just say, from my perspective about your career, like, there are very few people who have put together an IPU in real life and have had it sustained. In fact, outside of the Dell medical example, right, which is a very unique situation, I don't know if anyone's done the IPU to the fidelity that you have and kept it going. There's been centers of excellence and all that stuff, but very few have done what you guys have done. So I think it's deserving a lot of pride and praise. But what are you most proud of it, and what are you most excited about for the next step in your career?
So I think I'm lucky, Eric, to have a team that has the same passion for this that I have. Like, I'm not sure every organization is going to have the same sort of zealots, but my AP colleagues, my spine colleague, the behavioral medicine people are really fantastic in this, and our nutritionist is fantastic in this. It's been really, really fun working with these different folks in different specialties, and working together. Like, they're really interested in how we see things, and I'm really interested in how they see things. And I'm almost like a little kid. Like, I'm like, hey, I want to talk to the behavioral medicine people. Look, I really think this person really needs to see you. And then when they give me positive feedback, like, wow, Kelton, that was really good that you noticed that. I feel really good about myself. So I I think I'm proud of my entire team for being able to stand this up, withstand the criticism that came, because volume is everything in medicine right now, unfortunately. And there's a lot of volume pressure. And there was a lot of pressure to give up on this. And we didn't, because people believed in it. And so I think that's one of the things I'm most proud of, that we stuck with it. And I have to say, I want to give my entire team credit for that. The thing I'm most excited about is, because I'm old now, Eric, as of October 1st, I'm going to stop operating, and I'm going to dedicate my time to this effort. And I, you know, when it's time to stop, it's time to stop. I might have gone a little further had I not had this passion sitting right in front of me. And it feels great to have support from my organization for this next phase. And it feels great to want to dive in and take those next steps and really take this to the next level.
That's awesome. And I think um hopefully you continue to talk about this on the lecture circuit at our value-based courses, hopefully interested orthopedic leaders will look at this video as well. And I mean, there's a pathway to doing this. It requires a little bit of work, and it requires enablement of the team to do this and support, not only salary, but administrative time and all that stuff. But like if you're in a value-based healthcare organization, like this is going to save money. This is going to pay itself back. You're going to take better care of patients. They're going to want to stay with your hospital and healthcare system. So, I mean, obviously, I'm all for it, and I think a big congratulations, and excited to see how phase two goes on, and you dive into some of those other aspects. So, thank you so much for joining.